mm femoral head or 32 femoral head gives adequate stability, especially if your component position offset is right and component has been placed without anything being. Now understand wear. And if you are going to use a larger femoral head, it creates greater frictional torque and also creates more abrasive wear. And this is true especially if you are using a 36 head or a 40 head on a poly. This causes large generation of a poly wear debris. Now people have come out that now we are starting using a highly cross-linked poly, which actually is a good one. But then there are problems with cross-linked poly is that this highly cross-linked poly has a reduced mechanical property. You are cross-linking it more to make it much more sturdy, but these also release radicals or free radicals which are causing more osteolysis. So the generation of particle which was there with conventional poly is still there with the cross-linked poly. It loses its mechanical property, and larger the head you are going to use, the smaller the poly you have to use. So eventually either you are compromising on the femoral stability or you are compromising on the poly wear. And in a larger femoral head, especially if you are using a poly, the wear is going to be quite much. So that's a conclusion about the wear. In a standard poly, the larger head would obviously have a more volumetric wear, and the 36 and the 40 millimeter heads against a highly cross-linked poly at 5 years have shown much more volumetric wear. So if you are using a larger femoral head in a poly, also be understanding that poly wear would be too much. In addition, if there is a large head, it creates more torques. So the interface between the cement and the bone loosening are much more higher if you are using a 36 millimeter head or a 32 millimeter head. So torque actually increases as the femoral size increases. So if you look into all of these things, in addition, larger femoral heads have a problem which is called as trunnionisis. Trunnionisis means large head which goes onto the stem actually causes much more torque interface between the large head and the stem and causes trunnion wear, and this also creates debris and metallosis in the patients. So to conclude, if you look into all of these things, does it give you an advantage of using a large femoral head? If you talk about range of movement, it's a question mark because if these patients are arthritic, they are already quite stiff. So even if you are using a 36 head or a 40 head, you might not get adequate amount of movement which you were thinking. Does it increase stability? Yes, sure, it increases stability, but stability also is a component position importance. Does it increase wear? It increases wear quite a much. Does it increase the frictional torque? It increases the frictional torque and also causes trunnionisis. So for us as a surgeons who try to give a stable hip and more range of movement hip, shifting from a 28 to 40 is a dramatic decision. You should not take it. There are indications where you can use a 36 head, but you should not always try to go in for a 36 femoral head. Because if you use a 36 femoral head, probably you are increasing the surface wear, you are increasing the torque and loosening, you are increasing trunnionisis, and you may not be actually achieving a good range of movement in such patients. Larger heads are always to be used with hard on hard bearing, not on a hard on a soft bearing. So should not use a 36 head on a poly. If at all you are trying to use a 36 or a 40 head, use it as a ceramic on ceramic. Because here the wear patterns are totally different than from a poly wear. Here whatever is happening is a movement due to fluid lubrication. So wear is not the same kind of wear which happens on a poly and a metal. This wear is different, and that is why if you are going to use a larger diameter head, go in for a hard on hard bearing. Otherwise, in all our practices, try to stick at 28 or 32 because that's has got a maximum best outcome. Recommendations right now is position your vestibular component optimally. Consider more or less always a 28 or a 32 EVA, especially in a young hip which has been stable intraoperatively. Only use 36 and 40 head in high risk patients. These are patients which are elderly. These are patients which have got a fracture, so there is actually extensive capsular damage which has happened, and these are patients with neurological disorders like Parkinson's. So my conclusions right now is this, that in a primary ribs, try to use a 28 and 32 mm Larger than that, only use it for high-risk cases. If at all you are using a large head in a younger individual, go in for a hard surface like ceramic on ceramic and never a ceramic on a poly. In a revision total hip replacement, the scenario changes because these are patients where there is a high risk of dislocation. These are patients probably where risk of dislocation is much more than risk of wear. In such patients, use a large size femur. So in revision hip replacement, I don't have any problem of using 36 or a 40 depending on the case, but never use it primary. And nowadays there are tricolors and dual mobility liners which can be used for recurrent dislocation. So even in revision hip replacement, there are still recommendations that rather than using a 40 mm head, go in for either a dual mobility or a tripolar component. But in a primary, it's always good to stick to either 28 or a 32 mm. Okay. Thank you very much. Are there any questions on the outcome? That is what we say. Tripolars have right now been reserved only for recurrent dislocations. Probably as the indications are going to expand, the long-term outcomes are going to come. And maybe in future, if these stood to 20 years plus outcomes, maybe people start using tripolars for primary. Right now, recommendation is only for recurrent dislocation. Right now. So if there are no other questions, thank you very much.
Can you sit there? Because can you
32, never go to that.
In fact, most of the studies say that 32 head is the lecture I will get to now. And we will be starting this session. Unfortunately, because of the local problems, we will have to vacate the hall at 6 p.m. So if there's any issue, I think Dr. Vijay Bose has demonstrated his surgery so well that if I don't show another live surgery, that should work. But we'll see if there's a time. A video will be shown by Dr. Yadav. And if there's a time, I will, because what I wanted to show was, I don't use Charlie retractor now, this last almost 20 years. Initially I was using. I use special retractors, and I do not cut gluteus maximus. I do not cut piriformis in all the cases. In selected cases only I remove piriformis. These are the two things which I would have liked to show. Rest everything, the concept nobody can change. Access you can change, but the concepts cannot be changed. So what Vijay Bose showed, how to fit the acetabulum is same, how to fit the stem is same. So the axis can be changed, like the exposures can be changed, but the concept of the joint placement cannot be changed. The loading issue, the biomechanics, they will remain the same. So friends, that's all I would like to say.
Dislocation that is most common instability and dislocation is most common in early complication of total limb arthroplasty, and range is 2% in primary, less than 2%, and around 15% in revision it is reported, and Mayo Clinic reports 2.4% in the primary, 4.8% for the revision total limb arthroplasty, and around 70% they occurs in the factor that is not in our hand, surgery related factor, and that is in our hand, and most of the time dislocation they are because of surgeons, not because of patients. So most important is, especially in the posterior approach, component orientation. It is the, for me, it is the most crucial factor. And cup anteversion is more important. And because you can change the anteversion very much accordingly. In the femur, you cannot change much version. And femoral, usually femoral version is
10 and acetabular version is around 30, that is average. So overall combined anti-version is 40. If as Dr. was shown in that coplanar test, if it is 40, it means your version is okay and hip will not dislocate. And this is the beautiful photograph. It is showing white. This is too much antiverted. You can see here, this cup is coming out. It means it is too much antiverted. First of all, you can see this one, central one. It is all around matching from tall and all the margin of the ligament. It means it is natural version. As you have seen just now in the surgery, it means it is okay. Even inclination is okay and version is also okay. Now you can see this is more antiverted and this is retroverted, and this is, you can see this is tall. If it is going quite away from the attachment of tall, it means it is horizontal, or if it is coming out of tall, this lower border of the cup, it means it is vertical. So basically you can see it very easily with the experience, and if you have done the good exposure is very much important, especially on the cup side and especially in the cemented component. If you are doing cemented hip, then exposure should be better than uncemented hip. So these are the 3 cup position, limb length, these are the most important factors. If you go through the literature, whether posterior repair matters or not, this is a meta-analysis. It says previously there was more dislocation rate, 2 to 5%, even 10%. I have seen in my department. I spoken in my professor interview, contribution to the surgery and names. I quoted previous when we were not repairing that extended, I call it is a myocapsular sleeve. Then I have dug out all the OT ordered for last 7 years. Then we started repairing in 2006. After that, in our department, I am working with Dr. Rastogi. Most of you know Dr. Rastogi. You can inquire him. Dark dislocation, they are history in my unit. And why it is, this meta-analysis also says it is repair matters. As Dr. Bosch has shown you, it matters. It all happened because of proper version. These 2 things are in your hand: proper version and repair. And third important thing which you should ensure, there should not be any impingement. Ensure when you are doing range of motion after the trial or after the definitive implantation, there should not be any impingement. These 3 things are most important. So why posterior approach? I do from the, I am 100% posterior approach man, because it do not affect abductor, so no limb as told in the body. Good exposure and easy exposure, less blood loss with the posterior approach. And disadvantage, reported so-called say more dislocation. I do not agree with this. So now challenging issues remains how to reduce dislocation through the posterior approach, which is more biological. I call it a biological approach. And I do it differently, unlike Vijay Boss Bay. I will show it. And even I have video that will show in another lecture. This is, we call it as extended posterior myocapsular repair. It reduced dislocation significantly. It is studied, it reports like that. Now question is how to do. This is also important. सभी लोग पीछे से रिपेयर करते हैं, लेकिन वो डिस्लोकेट फिर भी हो जाता है उनका. हमारे यहाँ नहीं होता. Why it is so? So our study we have previously we were not doing, now we are doing. So only primary hip they were included in this study. Comparative evaluation was done. Group A, out of 233 hip, we all operated before 2007, and Group B, after that, we included in this 5, 6, 7 patient, and where dislocation that repair was done. So the overall result, I think one slide is missing. That I can let you know. In group A, there was around more 5 to 7% dislocation rate where we have not done the repair. And group B, there was 1 dislocation out of these. And when we started this repair. Now question is how to do it. This is very important. You have to do exposure, excellent exposure, and you can see piriformis tendon over here. After exposing the rotator, put stay suture from starting from the piriformis tendon and up to the quadratus femoris. I put 2 ethibond suture because it is big length, so you cannot do it with the and repair is better if you take 2 sutures. And now raise conjoint myocapsular sleeve with the help of cautery. What I do, I start cautery from here, piriformis fossa, piriformis tendon. Then I am over the posterior border of the trochanter up to the quadratus femoris. And I take out muscle and capsule as a single sheet. And after inserting the processes, attach sleeve over the superolateral border of the trochanter with the help of ethibond number 5. This is summary. And finally repair this. Sometimes you have to detach the gluteus maximus tendon as well. So I also repair gluteus that tendon, or so it support the deeper layer. So that is I also repair with the ethibond. So these are the various steps. Now we have taken suture. We have now this is I am using cautery all over. Then this is dislocation. Once you have as a myocapsular sleeve from the posterior border from here, now you can see the dislocation. Now after the implantation, this is closer, this is after the closure. So result there over here. So in group, this I have already told you, 1 out of 5, 6, 7 dislocation. And in total dislocation in group 1, they were 5% or even more than 5%. So now, why our technique is unique? I have presented this my work in many international platforms. First of all, we apply to suture in full thickness, extending from the, it is very simple, very easy. You can come to our OT, I operate twice in a week, you can see this thing. And I start from the piriformis fossa to quadratus femoris. Then we detach full thickness, this is in detail as I told you. And superior cautery, we start from the piriformis and go up to the quadratus femoris. After implanting the processes, repair is done with the help of, and important thing, most important thing, once you are tightening the suture, keep limb during the tightening in external rotation, extension and abduction. Then the repair is easy. You can come very close to trochanteric bosom. If you are repairing in this fashion, then this joint will not get any stability. So when you are tightening the suture, do external rotation, abduction and extension. That is most important when you are doing this thing. And so why this is bone to soft tissue repair? It is not soft tissue to soft tissue repair because it ensures fast healing and repair is more strong. It doesn't sometimes, what happens if you do soft tissue to soft tissue repair, it may break. It is reported in the literature. कई बार हमारे यहाँ पहले नहीं कराते थे, वो soft tissue to soft tissue करते थे, अरे ये तो टूट जाती है, कोई फायदा नहीं है. Now we have done many dozens of MRI after this repair within 6 months of surgery. These all repairs, they are all intact. And this is bone to soft tissue repair is more biological. And why we use ethibond? हर जगह मिल जाता है. Ethibond is available. And it is very cost effective and strong enough to resist forces generating during the physiotherapy. When patient is start mobilizing. Now question is why Ethibond 5? Because the needle is very strong. I do not do any drill. You can pierce any bone from Ethibond number 5. कुछ पेशेंट में प्रॉब्लम आती है स्ट्रॉन्ग यंग मैन में एवियन में उसमें भी इफ यू आर गुड एनफ यू कैन पियर्स द एवी ट्रोकेटर इट इज अ कैंसरस एरिया सो आई अवॉइड ड्रिलिंग द ट्रोकेटर स्पेशली इन द फीमेल एंड it can pierce and I use as I told you drill bit because sometimes it may cause fracture especially in the femur. Now what is alternate to this our technique? This is also reported in the literature. Other alternatives they have described many complex exposure like they avoid cutting the piriformis tendon and they avoid cutting the rotators. They do THR but without taking out the myocapsular slip. Then in this situation you can do the THR but it is very bad exposure or our patient they are very complex primary. Most of the time they come in very late stage. So exposure is not good. This also say if you avoid the piriformis tendon. So posterior approach never ever reduce combined antiversion. थोड़ा सा extra पड़ जाता है doesn't matter at all. But never reduce. This is the one of the key factors. And post-op many advantage mentioned in the studies, but has more dislocation. Don't do proper. I do proper repair as I mentioned. I emphasize is a full thickness myocapsular repair. So you can almost bring down dislocation rate to 0. Thank you. Especially is a matter of feeling and eyeballing. वो डेवलप हो जाती है बस सोचो ज़्यादा रीड बट बहुत ज़्यादा पढ़ते चले गए और कुछ सोचा नहीं मनन जिसे कहते हैं ना मनन करो चीज़ों पे सोचो
Do you leave the needle when you take a myoflap photo? Then the needle of the Ethibond
sutures they are like posteriorly. They are like
take two different and
because good thickness is good bite is there.
Right.
पहले मैं क्या करता था I used to take out this फिर I used to put
that's that.
but now I put it there then I repair from the same offset. तो आती नहीं है. There is a gaps remains even after external rotation. Then sir should be repaired. That was the very good question. करना चाहिए कि नहीं आप बताओ? Even then करना चाहिए नहीं भी आता है. Let it be gap once. Why? What happens? Dislocation होते क्या है? Dislocation होते हैं because of it will not allow uncontrolled movement of the limb which is responsible for the dislocation.
Dr. Yadav sir, मुझे बताओ मैं पढ़ रहा. So there are two. One is whenever we cut gluteus maximum from the linear for the better. Does it help in when repairing help in preventing the dislocation or rather it is not?
Sir, it is very thick thing and it what I feel it support your deeper repair. So there is no harm.
Is it not be just
ideally it should not be detached, but sometimes complex primary tight hip I make it partially. Sometimes it is not needed to cut that sheath, that tough structure. But I repair always.
So my submission is if you don't repair, it will help in preventing the dislocation. I repair, I know it, I cut it.
Basically, I feel it support the deeper structure. फिर dead space भी नहीं रहता है. If you do not repair, I repair from the tough sheet of that TFL and they combine.
That is a different issue, but just for preventing the dislocation, if we don't repair, it goes into favor of preventing the dislocation.
Very neat. Then I put drain. Otherwise, I routinely do not put any drain now.
I have a second question from a previous lecture. Is it triple taper has got some advantage over the dual taper? Is it not?
Double taper.
Then double taper is excitor, triple taper is C stem.
But I do not discourage cemented hip because I have Ross Crawford is my very good friend and I have been to his center for 2 months. Long taper is better than triple taper. Dr. Vijay Boss can comment over. Do you use cemented? So I have not much knowledge. Whatever I have gathered from the literature or which I have registered in my mind, double taper is better than triple.
Why do you want to?
Maybe
how can you say, Dr. Vijay? Is there any some study or we are saying by
study is the gold standard. Exeter is cemented gold standard in the world.
Got the best result of
सब उसी के बेस पे ऐसा होता है.
triple taper is a C stem from the dead. And Exeter come from the striker. So is there in some study or by our experience we are saying?
The studies, registries are there.
This one has got the best results, yeah. So
Registry.
But the system also has got a very good result. Not to see also very good results.
Either equal or
English female patients, we don't require the gluteus maximus. They'll have sagging of buttocks on one side. So that's the.
So that is the difference between the skirt and sari. But I repair it just out of curiosity. I was asking, and I.
Whatever tissue take off is good idea to repair. I think
Well,
it's great idea.
nature को वही पहुंचाओ जहाँ से nature आई है.
Pardon that?
Nature जहाँ को nature को आपने छेड़ा है उसको repair करो.
But how does it prevent? Not repairing. How does it
I
prevent?
do not know. मैं तो पूछ रहा हूँ. I
अरे सबको
मैं सामने बैठा हूँ.
वो है हमारे कुछ.
See, I think you comment, not repairing prevents.
Because do you understand little bit Hindi?
I understand. Yeah.
Because you are from Tamil Nadu. Any question?
Into the greater trochanter and repair the capsule in toto along with the external rotator and take out from the greater trochanter and repair it. The same thing I think the same.
Extended biocapsular.
Yes.
Without breaking chance in it. Ethibond 5
That's a good idea. That's a good idea because Ethibond has got a very strong.
Five, not two.
Five.
Five की needle बहुत strong है. फ्री में मिलती है, सरकारी सप्लाई में आती है. Ethibond is costly, otherwise suitable. Thank you.
So that was a very nice talk, sir.
Blasting, pinnacle is an example, HA quadrant, trident cup is an example, ingrowth and outgrowth is discussed in the morning, so I won't go into that. Methods to improve stability of the cup, we talked about screws. Generally, it's a good idea not to apply screws because then you are getting better the technique of getting press fit. So press fit is the primary mode of fixation. Accessory modes are screws and spikes, etc. Now, when does unsymmetric devices fail? When you have deficient host bone, where less than 50% you have host bone contact, or support critically support segments are there, but if you don't have those segments, and the important thing is lack of press fit. If you don't have the press fit, the cup will fail. Do not expect a dangling cup, you don't get any press fit. You put some screws, everything looks okay on the X-rays, that cup will not have long-term success. It only have fibrous ingrowth, it will not osteointegrate. So non-symmetric socket is not about screws, it must be about the press fit. So conceptually, one must learn to get stability without screws, and that's the reason why we say that you must learn to put and use screws only if required and not on a routine basis. Over-dependence on screws is a recipe for disaster. Screws give additional stability and not the primary mode of stability, very important. Primary stability is always the press fit. So I've done a lot of motor blocks. Motor blocks you can't put screws, even if you want to, you cannot put screws. So we've done about 2,300 over the last 15 years. We've had only one cup loose without screws. So it's all about the press fit, not about the screws. So how do you get this press fit that you're talking about? I was trying to show on the demo. You must have a good familiarity between the relationship between the trial and the implant. All implants, trial and the actual implant is 0.5 mm, sometimes it will be 0.75, sometimes it will be 1 mm, sometimes it will be 1.5 mm. The striker accolade is the one, the trident is the one which has got the maximum difference between the trial and this thing. So you must know your implant can vary from 0.25 to 1.5 millimeters. It's a huge difference. So you must know your implant very well and your trial very well. The surgeon must ensure that the trial for that particular implant gives the same fit. So you're trying to see whether that fit of the trial is what you want in every patient. For example, if you are doing a neurolog, the trial must be very tight. Not tight, it's going to be loose. The trident, the cup must be loose. The trial must be loose, otherwise your actual implant will not go in. So you must learn what your implant is all about. Yeah. Surgical tip number 2 is that do not blindly depend on reamers. It's a very, very important point. Now suppose I'm using a 50 cup. You routinely say I ream 49. Not in all patients. Because the amount of reaming depends on 3 things. The sharpness of your reamers. So it's been in our country, the set goes from hospital to hospital for many years. and they are not what they say 49, they may not be 49, they may be only 47 or 48, so that's where they can go wrong. The coverage determines how much you ream or not ream. The bone quality, today you see very soft bone, so these three factors will determine how much. So don't blindly say a 50 cup, I will ream 48, put a cup. That you will not get your breast fit all the time. So for a given cup size, I may under ream by 2 millimeters. I may under ream by 1 millimeter. I may do line to line reaming. Rarely, I may do 1 millimeter over reaming. It's sclerotic bone.